Pelvic examination for OSCEs. The objectives of this recording are to understand the reason for performing a pelvic examination, to know the issues around consent and chaperones, and to be knowledgeable in the procedure of pelvic examination. People can fail this station because they get embarrassed talking to female simulated patients, or because their technique is poor and they don't know how to handle a speculum or the relevant swabs. There are many reasons why women may have to undergo a pelvic examination. Firstly, to take a cervical smear as part of the National Screening Programme. Secondly, in cases of suspected genital tract infection, either by a general practitioner or in genitourinary medicine clinic. To assess pelvic pain or dyspareunia. To assess menstrual disorders. To assess the degree of prolapse. To understand early pregnancy problems, and to assess a pelvic mass. The equipment that you will need in this OSCE station includes alcohol, non-sterile gloves, an appropriately sized speculum, usually plastic but maybe metal, appropriate lubricant for the model, a smear brush and a cytology pot or swabs as required by the question that you've been asked, and a light source. Your introduction is the key to a good start to the station. Wash your hands and introduce yourself to the simulated patient using your full name and as a medical student of the appropriate year. Confirm you have the correct patient and explain what you'd like to do. Ask the patient to undress completely from the waist down and provide them with something to cover themselves with. It is good practice to ensure that the patient has emptied their bladder, as this will make the examination much less uncomfortable for them. Start your inspection from the end of the bed, looking for signs or sequelae of menstrual problems or other gynecological disorders. Hirsutism, acne and raised BMI may be signs of polycystic ovarian syndrome. Look for normal development of secondary sexual characteristics, namely breast development and pubic hair, and look in the eyes to check for pallor, as severe menorrhagia may cause iron deficiency anemia. Moving on to the perineal area, look specifically for swellings, scars of previous gynecological surgery or previous childbirth, visible discharge, signs of sexually transmitted infections such as warts, herpes, etc. Visible prolapse. If a prolapse is not visible and the patient has complained of prolapse symptoms, you could ask the patient to strain down to see if this makes something more visible to you. You could also assess at this point for signs of stress incontinence. However, if you just ask the patient to empty their bladder, then you will not be able to elicit this sign. It is good practice to perform an abdominal examination before performing a vaginal examination. Usually in OSCE stations there will not be time for this. To move on to the vaginal examination, in real life you would use KY jelly to lubricate your fingers, but silicone gel has been developed specially for the models. Insert 2 fingers of your right hand, warning the patient before you do so. Assess the vaginal walls. These should be smooth, warm and moist with a normal tone. And assess the cervix, which should be smooth, mobile and non-tender. You may be able to get an impression of whether there is a multips or a nullipsos. Using your left hand to palpate the abdomen, starting from the umbilicus and working downwards, assess the size of the uterus. The uterus should be mobile and non-tender and easy to lift out of the pelvis. In most women the uterus is anteverted, i.e. it lies forwards towards the bladder, but in 15% of the population the uterus may be retroverted. You'll be able to tell this because the cervix would lie more posterior to your examining fingers and it may be difficult to lift out of the pelvis. Then palpate in the adnexi for any adnexal masses. It may be possible to palpate normal ovaries in slim patients, particularly under general anaesthetic, but it is also normal to be able to feel nothing in the adnexi. If you do feel an adnexal mass, describe it in terms of size, fixation and tenderness. To move on to the speculum examination, first lubricate the speculum. Warm water may be useful for metal specula which may be cold. If you're taking a smear, you must not use oil-based lubricant because this interferes with the fixing of the cells. However, most water-based lubricants are acceptable when taking a smear. Insert the speculum with the blaze closed and the handle in the transverse and rotate it as you insert it. This is the most comfortable for the patient. The cervical smear takes cells for cytological assessment. It is carried out with 5 360-degree rotations of the cervical brush. There are 2 types used commonly in clinical practice. The first, Cellsure, has a blue brush and a blue pot. Once you have taken the smear, you need to remove the end of this brush, place it in the pot and replace the lid. The thin prep type involves a green brush and a white pot. The end of the green brush should be agitated in the culture fluid, but the end of the brush is not removed before the lid is replaced. The next test, if you have been asked to do it, would be a high vaginal swab. This is a standard charcoal swab that is sent to microbiology. If any discharge is visible, this is what should be obtained using the swab. It is passed around the vaginal fornices and placed into the tube. The next swab will be an endocervical swab for chlamydia. Chlamydia is more commonly tested for in recent times by using a urine test, but if a speculum examination is being done anyway for another reason, then it is common to take endocervical swabs for chlamydia. It has to be extracted via PCR as it is an intracellular organism. Chlamydia swab packets come with 2 swabs, one to clean and one to swab. The swab is always longer than the bottle and you must break up the end of it in the collecting bottle and replace the lid. To remove the speculum, use direct vision and take care not to trap the cervix, the vaginal walls or the patient's pubic hair in the blades of the speculum. It should be rotated in the reverse order to which it was inserted. You should provide the patient with wipes and sanitary protection if appropriate, depending on what tests have been done. Always explain findings to the patient after the patient has dressed and not before, and tell the patient how they would receive the results of any tests that you have done. In summary, ensure you have the patient's consent, ensure you have a chaperone with you and that the patient is as comfortable as is possible. Don't forget to inspect the vulva before palpating the pelvic organs and assess the cervix plus any further investigations via a speculum examination.